السلام عليكم. بسم الله الرحمن الرحيم. اللهم اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. In the beginning, I would like to express my gratitude to Professor Said Abdul Hamid for giving me the opportunity to be with you today. Also to Professor Hamdi Tamam for his continuous support. Our session today will be rather light. We will talk about distal radius dorsal bridge plate. Distal radius fractures represent the most common upper extremity fracture, 1/6 of all fractures presented to the emergency department, and the third most common fragility fracture following vertebral and hip fractures. They are more common in females. It has a bimodal distribution, younger patients due to high energy trauma, and older individuals due to low energy trauma. The treatment options varies from conservative measures to surgical interventions based on fracture morphology and patient criteria. Surgical options include percutaneous pinning, internal fixations with various plates and external fixator, dorsal bridge plating. The general rule for intra-articular fractures is anatomical reduction and absolute stability. That's the general rule, but sometimes you cannot play by the rule. You play with what you have. So in severely comminuted fractures, you need to indirectly reduce the fracture using ligamentotaxis. Indicated dorsal bridging plate is indicated for extensive articular comminution or extensive metaphysio-diaphyseal comminution. Preoperative assessment, of course, laboratory investigations, standard X-ray views, posterior, anterior, and lateral views. CT is extremely important to provide us with the information necessary for understanding the fracture morphology. Surgical technique. Planning is by starting by the incision in the second web space. Then using Freer elevator, we retract the extensor tendon. Insertion of the plate from in a retrograde fashion. Distal fixation through the incision to either the second or the third metacarpal bone. The assessment distracts the fracture. The reduction is confirmed by the image intensifier. في مشكلة. After confirmation of reduction by image intensifier, proximal fixation is done. Post-operative care, immediately medications and splinting for 1 to 2 weeks, and of course exercise for the hand. Radiological evaluation at 1.5 and 3 months. Usually he will need a second procedure to remove the plate at 3 months. Patient assessment, clinical evaluation, range of motion, grip strength, visual analog score, and a validated Arabic version of quick dash score, and of course a radiological evaluation. There are a few points that I will need to clarify. When we talk about dorsal bridging plate, there are a few questions that pop in our minds. ده لسه الوقت يعني. لا ده هو فصل. As to which metacarpal bone should we fix, the second or the third metacarpal bone? which is better, dorsal bridging plate or volar locking plate or external fixator, and what are the outcomes of dorsal bridge plating. There is a systematic review published just 2 weeks ago, too fresh, comparing fixation to the second metacarpal versus the third metacarpal. The second metacarpal group demonstrated greater range of motion, greater grip power, and less incidence of tendon rupture. When we talk about dorsal bridging plate outcomes, there are various studies that demonstrate patients retaining good functional and radiological outcome and retaining functional range of motion using dorsal bridging plate. So what should I choose, dorsal bridging plating, external fixator, or volar locking plate? A nice collaboration between Sohag University and Kenya University, Professor Ahmed Dusougi, Professor Said Abdel Hamid, Professor Mohammed Ali, Professor Mohammed Abdel Wanis, and Professor Soliman, my friend Dr. Ahmed Abdo, published this randomized controlled trial in Injury Journal, comparing the dorsal bridge plating versus external fixator. The group undergone dorsal bridge plating demonstrated earlier recovery. However, at 12 months follow-up, both groups demonstrated the same functional and radiological outcome. A study we conducted here in our department, comparing between dorsal bridge plating versus a volar locking plate. We have two groups. A group of 10 patients underwent dorsal bridge plating versus a group of 9 patients underwent volar locking plate. Both groups demonstrated the same functional outcomes and almost the same radiographic outcomes, except for maybe volar tilt was a little bit better for a group of volar plating. The study showed better radiographic outcomes in the group undergone volar locking plate compared to dorsal bridging plate. However, no technique showed functional superiority over the other at 1 year follow-up. Of course, plate remove. I stated that plate should be removed at 3 months after confirmation of radiographic union. 3 months. At 6 months. At 6 months بنأسس احنا على 3 شهور بنشيل البليت في الدورزال بريدجنج بليت. بنشوف على 3 شهور على بعد 3 شهور من الريموفال التو جروبس كان الجروب بتاع الدورزال بريدجنج بليت والجروب بتاع فولر لوكينج بليت كفانكشنال اوتكم ما كانش فيه اختلاف كبير. الفولر لوكينج بليت كانت افضل شويه راديوجرافيكالي خصوصا في الجزئيه بتاعه الدورزال تيلت الفولر تيلت ما كانش فيه حالات فيها دورزال تيلت لكن كفانكشنال ما كانش فيه اختلاف كبير. يعني هو ده انا هحدد بناء على الفراكشر مورفولوجي. لو انا هقدر احصل على anatomical reduction من خلال الفولر لوكينج بليت I will go for volar locking plate. اكيد. بس احيانا الفراكشر مورفولوجي ديكتيتس يعني
هو جايز هو جايز برضو يا دكتور محمد يبقى important في الستادي دي ان هي تبقى مثلا randomized controlled او ان هي تبقى مش بتنقي مين اللي يتعمل له كده ومين اللي يتعمل له كده لو احنا عايزين نعمل كومباريزون. هينقي الحاجات اللي هي زي ما حضرتك بتقول كده، ان انت تبقى سيلكتيف الحاجات بتعمل لها بليت اللي انت تبقى شايف ان هي هتبقى بيرفكت ريدكشن، والحاجات اللي كومينيوتد هنعمل
ده حسب الفراكشن.
فانا قصدي if we're going to do a study to compare فيبقى ما نبقاش سيلكتيف. لو احنا we selected هيبقى it's as if احنا عاملين 2 كيس سيريز. بس انا اول مره اعرف البريدجنج بليت، يعني قصدي it's فكره كونسبت موجود.